Well, good afternoon, everybody. My name is Bernard Keaveney. I'm a professor of cardiovascular medicine in the University of Manchester and a consultant cardiologist at Manchester University Foundation Trust. I chair the MAHSC cardiovascular domain, and it is a great pleasure to have so many joining us today for this MAHSC Seminar Series. Now, I'm sure I don't need to tell anyone that cardiovascular disease is an absolute scourge of our conurbation. Manchester has just about the worst morbidity and mortality from cardiovascular disease in England, and it is a profound source of health inequality. And in the Academic Health Science Centre, we're doing our very best to turn that around through commitment to our threefold mission of research, training, and excellent clinical practice. In the MAHSC cardiovascular domain, we have clinical involvement prominently from MFT and the Northern Care Alliance. We have great academic colleagues, not only from the University of Manchester, but also from MMU and Salford universities. And we are actively pursuing a one Manchester approach to really try and turn this around for GM. And it's a great pleasure to introduce two colleagues today who are right at the forefront of that to give you today's presentations. The first presentation will be from Dr. Chris Miller. Chris is a clinician scientist. He's Manchester through and through. He graduated here. He did his PhD here in his clinical training. And he is completing an NIHR clinician scientist position at the moment. And he's just found, sorry to embarrass you, Chris, that he will be getting an NIHR advanced clinical fellowship shortly. That has been confirmed. Chris is the director of the Manchester Centre for Heart and Lung Magnetic Resonance Research, a BHF sponsored initiative which has just opened its doors in November with a state-of-the-art clinical and research magnet, which is going to really turbocharge our capacity to do translational research in cardiovascular medicine in Manchester. And finally, Chris won last year the Michael Davies Early Career Researcher Award from the British Cardiovascular Society. This is the highest award for somebody at an early career stage in our specialty nationally. So we're greatly looking forward to what he has to say. And Chris, I will hand over to you now.
Thanks, Bernard. Can you see my slides?
Yes.
Great stuff, thank you. Okay, good afternoon, everyone. Thank you very much for the invitation to speak today. In this talk, I will give an overview of some of the work that my group is conducting. So, to quickly introduce myself, as Bernard said, I've recently finished an NIHR clinician scientist and will shortly take up an advanced fellowship from NIHR. I'm primarily based at MFT, Manchester Foundation Trust, and I split my time between clinical and academic time. So, this editorial in JAMA in 2013, many of the themes of which went into this consensus document in 2017, was a catalyst for the direction of much of my research. Butler and colleagues identified a disconnect between phase 2 and phase 3 drug trials in heart failure, which means that often, despite promising results at phase 2, most phase 3 trials prove neutral. The postulated reasons for this include a lack of understanding of prognostically important pathophysiological mechanisms and an inability to identify them, which means that there's a failure to target key mechanisms, as well as inadequate phase 2 endpoints and a one-size-fits-all approach. This outstanding program of work investigating the angiotensin receptor neprilysin inhibitor Entresto in heart failure with preserved ejection fraction, which is conducted by one of the leading heart failure trialist groups in the world, serves to demonstrate some of the issues that Butler identified. Natriuretic peptides, whilst transformative in terms of diagnostic confidence for heart failure with preserved ejection fraction, are not reflective of specific disease mechanisms and therefore do not provide feedback on whether or not an intervention has modulated the mechanism it was designed to target. As such, interventions are associated with an improvement in natriuretic peptides at phase 2 have often not translated into improved clinical outcomes at phase 3. Furthermore, potentially impressive efficacy in some subgroups at phase 3 suggests that stratification according to disease mechanism, rather than a one-size-fits-all approach, may be beneficial. It is with these words of Butler in mind, who described the need to connect cardiovascular biology with drug mechanism of action, that my program aims to use cardiovascular magnetic resonance, or CMR, in order to develop biomarkers of cardiovascular disease mechanisms and use them to identify targets for intervention and to evaluate novel and repurposed therapeutics. Extracellular matrix expansion is a key component of ventricular remodeling. James Moon's group from UCL originally developed an equilibrium contrast CMR technique that provided non-invasive measurement of myocardial fibrosis, but the method was quite tricky and not widely adopted. In this study, we performed a dynamic equilibrium contrast CMR technique that involved something called MOLY T1 mapping, which is just a cardiac MRI technique, which we applied before and after a gadolinium contrast agent bolus in patients awaiting heart transplantation. When they received their transplant, we measured the collagen volume fraction in each of the 16 segments of the explanted hearts. We found a strong linear correlation between CMR-derived extracellular volume, or ECV, and histological collagen volume fraction, which was strongest when the post-contrast images were required at 15 minutes. The relationship was maintained throughout the entire heart, and when segments containing infarct typical and infarct atypical focal fibrosis were excluded. The ECV measurement varied according to contrast agent dose, myocardial region, and sex, which demonstrated the importance of controlling for these factors. The technique has been widely applied. Indeed, while the pathophysiological relevance of the myocardial interstitium has been recognized for many years, it is with the advent of this ECV technique, which permits human studies of sufficient scale, that the clinical implications of myocardial fibrosis are becoming apparent. Across a number of conditions, myocardial fibrosis measured using ECV is consistently associated with adverse outcome. Myocardial inflammation is widely hypothesized to be a key cardiovascular disease mechanism, but evaluation of myocardial inflammation in humans is challenging. Circulating inflammatory markers are not specific to the myocardium, and standard cardiac MRI techniques such as T1 and T2 and PET techniques are not specific for inflammation. Ultrasmall superparamagnetic particles of iron oxide, or USPIO, magnetic resonance imaging, potentially allows specific identification of myocardial inflammation. The Edinburgh group in particular have done seminal work in the field. However, it's not been exactly clear what this USPIO MRI signal represents. In this study, we used a murine acute myocardial infarction model to show that these small particles of iron are both phagocytosed by cardiac macrophages, but are also passively present in the myocardial interstitium. This is an important finding because it demonstrates that the presence of USPIO in tissue is not specific for macrophage activity or indeed inflammation. And therefore, if USPIOs are to be used to accurately detect macrophage activity, the in vivo technique for their detection, i.e. MRI, must be able to differentiate active macrophage USPIO uptake from the passive presence of USPIOs in the interstitium. We therefore developed a multi-time point, multi-paramagnetic MRI protocol that does just that. We showed that while these MR parameters called R1 and R2 time courses are both affected by dissolved iron particles distributed throughout the tissue interstitium, R2 star is also sensitive to phagocytosed USPIO, whereas R1 is not. This is most clearly seen in the spleen in the figure on the left, which has high macrophage activity. We went on to identify a novel metric, R2 star R1 ratio, which provides a quantitative measurement of active macrophage ion uptake normalized for background passive tissue distribution. Respiratory and cardiovascular disease frequently coexist. In collaboration with Rahul Potlori, we conducted this large cohort study, which included nearly 3 million years of patient follow-up. It showed that, for example, COPD is associated with heart failure, independent of shared risk factors, and heart failure, perhaps as expected, independently contributes to all-cause mortality of patients with COPD. We then went on to look into why COPD is associated with heart failure. In a large cohort of patients undergoing CMR across 2 sites, we found COPD to be independently associated with myocardial fibrosis, as measured using CMR ECV. On Cox regression, we showed that in patients with COPD, myocardial fibrosis is independently associated with hospitalization for heart failure and all-cause mortality. Indeed, myocardial fibrosis associated with the outcome measurements more strongly than any other variable, including the key COPD index, FEV1. The findings could be used to improve risk stratification and potentially provide a target for intervention. Persistent myocardial inflammation is widely hypothesized to be a key driver of adverse left ventricular remodeling and heart failure, although there is very little evidence for it in humans. Using our USPIO MRI technique, we demonstrated evidence of persistent active inflammation in the infarcted and in the remote myocardium in chronic ischemic cardiomyopathy, a median of 1.4 years post-myocardial infarction, thus providing direct evidence for a substrate for this hypothesis in humans for the first time. In the same study, we showed that the myocardial response to injury is not generic. Active macrophage infiltration in myocardium does not necessarily go hand in hand with myocardial edema. For example, in acute myocarditis, despite evidence of myocardial edema, there was no evidence of active macrophage activity. Finally, moving on to intervention. In work led by a collaborator, Eric Shelbert, myocardial fibrosis measured using CMR ECV is strongly and independently associated with adverse outcome in heart failure with preserved ejection fraction. However, demonstrating the heterogeneous nature of this condition, histological and imaging studies have shown that potentially a third to a half of patients with this heart failure with preserved ejection fraction do not have myocardial fibrosis, often despite having evidence of diastolic dysfunction. Pirfenidone is an oral antifibrotic agent licensed for pulmonary fibrosis. It inhibits fibroblast synthesis and secretion of TGF-beta1, fibroblast proliferation and activation of pro-fibrotic pathways. In preclinical models, such as this pressure overload model, it significantly reduces myocardial fibrosis, seen with the blue stain. Pirfenidone is also interesting from a mechanistic point of view because it doesn't affect blood pressure, and thus in this sense, it is a specific antifibrotic. We designed and conducted the Pirouette trial, in which patients with heart failure with preserved ejection fraction underwent CMR at baseline, and only those with evidence of myocardial fibrosis, determined using a pre-specified ECV threshold, were randomized to pirfenidone or placebo for a year. The primary outcome is change in myocardial fibrosis measured using ECV. A sub-study investigated the relationship between myocardial fibrosis and myocardial energetics using phosphorus spectroscopy. Thus, in line with Butler's comments, we use CMR to connect a prognostically important biological pathway with drug mechanism of action. We selected patients with evidence of this disease mechanism for entry and used a primary outcome measure that is tailored to the mechanism of action. In designing the study in this way, we believe that the results will better inform the decision as to whether or not to progress to phase 3. Recruitment and follow-up were achieved to target, and the data have been analysed by the trials units. The results are under peer review, therefore I'm not able to describe them today, but we will be presenting some of the results as a late-breaking clinical trial at the ACC in May if you're interested in finding out more. Finally, as Bernard said in his introduction, I'm very happy to say that our cardiovascular and respiratory research MRI scanner, which has been supported by the British Heart Foundation, by MAHSC, by MFT, by the university, and a number of charitable organisations across Manchester, is now fully operational. The scanner is currently supporting 5 studies, and 6 more are due to open over the next couple of months. As a few examples, we are conducting 2 urgent public health studies that are investigating the cardiovascular impact of COVID. And you can perhaps see some of the myocardial injury that we observe with COVID in this late enhancement image, where you can see the bright areas which are associated with edema and fibrosis, and in this T1 map where we see this purple area of injury. We've also recently opened a multi-centre phase 2 randomised controlled trial of a repurposed therapy in patients with hypertrophic cardiomyopathy. This is something that we investigated initially as part of an MRC Confidence in Concept Award, and now this trial is funded by NIHR EME and also in partnership with industry. Many of the outcomes are CMR measurements, including the primary outcome, which is change in myocardial mass, and then key mechanistic outcomes such as change in myocardial fibrosis and change in myocardial energetics. The data I presented represents a huge amount of work from a lot of people, and I would like to acknowledge and thank them. And if you would like to find out more about the scanner and how it could potentially help your research, then please do get in contact. Thank you very much for listening.
Chris, thank you very much. That was a great talk. I think since we last spoke, you've had the news about the late-breaking clinical trial at the ACC. Many congratulations on that. That is a terrific achievement. So we're going to take questions for both presentations at the end, after both presentations have been made. So now I will welcome our second speaker, Anil Malhotra. Anil is a Presidential Fellow at the University of Manchester, a Senior Lecturer and Honorary Consultant Cardiologist at MFT. His interest is in inherited cardiac conditions and sports medicine. Anil is a graduate of both Cambridge and Oxford. He did his clinical training in a variety of places, including Oxford and St. George's Hospital. His PhD work at St. George's with Sanjay Sharma was published in the New England Journal of Medicine. And he is rapidly establishing himself as a coming leader in sports medicine, sports cardiology in the UK. He's an advisor to the Football Association and is on their cardiology panel, an advisor to British Cycling. And since his arrival in Manchester, he's set up also some very exciting collaborations with the Manchester Institute of Health Performance. And Anil's going to talk to us about cardiac imaging and sudden cardiac death in athletes. Anil, thank you very much.
Thank you, Ben. Can you see my slide there?
Yes.
Thank you. Well, good afternoon, everyone. It's an honor and privilege to give this talk and an insight as to what we're doing from a sports cardiology and exercise perspective up here in Manchester. I think exercise is one of the only things that was actually allowed during the pandemic, and it highlights the emphasis of this as an interventional modality in those who do have cardiac conditions, but also as a preventative strategy as well when it comes to addressing risk factors associated with cardiac disease, be it as an adolescent, and that is where I'm going to focus some of my talk on, but also at the other end of the spectrum with an increasing population of veteran athletes or mammals, these middle-aged men in lycra that I am fast approaching, having suddenly discovered a passion for cycling. But I'd like to impart some of the work that has been done in the field and some of the projects that I wish to take off the ground using Manchester as a platform for that, focusing on cardiac imaging and sudden cardiac death in athletes. We know, bless you, we know that there's up to a 20% increase in left ventricular wall thickness amongst people who exercise, and all it requires is 4 hours of intensive exercise or moderately intensive exercise every week in order to manifest some of these adaptations. Now, this is an echocardiogram or an ultrasound scan of the heart that shows the heart inverted upside down as it is portrayed when we image this being the left ventricle, i.e. the main pumping chamber of the heart, and this being the right side, the right ventricle, with the atria, which are the smaller chambers lying on top, and the valves in between. And what we look for is a change in cardiac dimension to ensure that the cavity size isn't overtly enlarged or the wall thickness isn't abnormally increased either, because there's an overlap between these conditions, such as cardiomyopathy, i.e. heart muscle disorders, and physiological adaptation from exercise. There are a number of electrical adaptations, including sinus bradycardia, which is a low resting heart rate, but you can get other funny changes on the ECG as well. Structural changes like increased cavity size and wall thickness, and it makes differentiating pathology from physiology particularly troublesome. And I'll explain the implications as to why that is. But we do have to take into consideration a number of factors that influence the extent to which the heart adapts to exercise, be it age, ethnicity, gender, sporting type, and size. And they all have a variety of influences to varying degrees on the structural and electrical adaptations, with the overarching aim to improve the functional ability of an exercising heart to meet the demands of peripheral metabolism. There is an overlap with disease, and perhaps it takes a trained eye, but one can appreciate perhaps that this particular wall thickness on the left echocardiogram is thicker compared to something like this, where the wall thickness is within normal. But that may lead to the suspicion of a condition called hypertrophic cardiomyopathy. We know that certain groups are at particular risk of developing pathological conditions, and milder forms can pose the challenge to differentiate such physiological changes from adaptation, which is pronounced amongst Black athletes and also amongst endurance athletes. And I want to just talk about that a bit later as well, because these are two groups that demonstrate the largest sorts of cardiac dimensions and abnormal ECG patterns, the ECG being the electrical trace of the heart that we can see up here in the top right. The visibility afforded by sudden cardiac death amongst athletes and the number of life years lost in all young people falling victim to quiescent yet potentially sinister disease has resulted in a number of initiatives to identify individuals who may be at risk. And these are initiatives that have been advocated by scientific organizations such as the European Society of Cardiology and the American Heart Association, and then adopted by several sporting organizations worldwide. But these include mandatory cardiac evaluation in sport, using an ECG, i.e. the electrical trace of the heart, plus or minus echo, voluntary charity-based cardiac assessments, such as cardiac risk in the young, which are community-based assessments, often funded by bereaved families of individuals who have lost a loved one at a young age from a cardiac condition. And the number of people who die per week are estimated at 16. Between 12 to 16 young people aged between 14 to 35 die in the UK alone per week. So that's nearly 1,000 per year. And when one considers the number of life years lost, if a 16-year-old was to live up to 70 or 80 years of age, that has a huge societal, economic, and emotional impact. Of course, we run dedicated inherited cardiac conditions and sports cardiology clinics in the NHS, and therefore symptomatic young individuals are assessed, and there is a genetic predisposition of these conditions as well. And therefore, in some cases, there's a 50-50 chance that a first-degree relative may have passed a condition on, and therefore there is a familial component and a genetic component to what we do. Ethnic variations in making this call between physiology and pathology have been noted, between black and white adult and adolescent athletes in terms of left ventricular wall thickness. In fact, we reported that 12% of black athletes actually have a wall thickness that lies above what would be considered the upper limit of normal, i.e. 12 millimeters, compared to just 3% of white athletes. And this histogram shows black athletes represented by the black bars and white by the white bars. And therefore, this would normally raise a question of hypertrophic cardiomyopathy. We know that black athletes who compete at every echelon of recreation and elite sport demonstrate more ECG changes, such as T-wave inversions, which are hallmarks of heart muscle disorders known as cardiomyopathy. And they also demonstrate an 8-fold higher degree of left ventricular hypertrophy or thickness. And therefore, the challenge to differentiate the two from cardiomyopathy becomes particularly difficult. In football, the estimated, or one of the more recent reviews estimated the prevalence of sudden cardiac death at just 1 per 100,000 person years. And I believe that to be a grossly underestimated figure. And I'll tell you why, because the visibility of such tragedies in a sport like football is amplified. It's the world's most popular sport with nearly, I think, 250 million registered players. And although numerous high-profile sudden cardiac deaths have occurred, or arrests, such as the one shown by Fabrice Muamba in the center of the picture there, they receive much media coverage, and in today's day and age of social media as well, you get almost instantaneous questions through Twitter and WhatsApp about such incidents. But the challenge of defining a denominator amongst a nation, the world's most popular sport, as well as only hearing about the most high-profile tragedies, represents just the tip of the pyramid, and it poses a challenge to estimating the incidence of sudden cardiac death in this sport. And over the past few decades, there's been a wide range when reporting the incidence of sudden cardiac death amongst young athletes. And this is dependent on the population studied in terms of age, athletic status, and ethnicity, the sporting type, and methods of actually obtaining the mechanisms of and records of sudden cardiac death in the absence of mandatory registries in most countries. But what is apparent is that we do need large, well-defined populations to generate a significant number of deaths to adequately study incidence and provide longitudinal outcome data. In fact, this was an excellent study by Kimberly Harmon and John Dresner's group, which is 10 years old now, but involved interrogating the National Collegiate Athletic Association NCAA athletes in America, and they demonstrated that the highest rate of sudden cardiac death was amongst basketball players, and one of the most striking findings was a 4-fold higher risk of sudden death amongst black male basketball players compared to white. So what's it about basketball? I mean, we know that there are sudden cardiac arrests in football as well, most commonly as a sport, but it's thought to be a dynamic sport, both of them, that tends to select out a certain habitat, certainly habitus, and certainly basketball does. But the start-stop components, the sudden explosive adrenaline surges, and increased participation of black athletes, a few commonalities between these two sports. And now I'd just like to briefly share our experience of screening adolescent footballers in England. And this was a study based on over 11,000 16-year-old football players who were screened over the last 2 decades. And what we found through a fairly rigorous reporting registry, media reports, and also contacting each of the 92 professional clubs was that the overall incidence of sudden cardiac death amongst a well-defined denominator and a pretty well-defined numerator was at least 6.8 per 100,000, so nearly 7-fold higher than anything that had previously been reported. And there was a 6-fold discrepancy in sudden cardiac death when we compared white with black individuals, to highlight the need for more work to be done in these groups of adolescent athletes and those of different ethnic backgrounds. If one considers the demographics of sudden cardiac death, the largest case series amongst young athletes that was published by Barry Maron's group in America. And it shows that nearly half are attributable to cardiomyopathies, i.e. heart muscle disorders. A quarter are due to congenital and anatomical abnormalities, and a small proportion due to electrical disorders, with coronary disease accounting for only a very small proportion, and that isn't surprising given that these individuals are aged 14 to 35. So coronary disease plays more of a role after the age of 35, and that's something that I will touch on as well. But it does become apparent that those aged 17 or less are particularly vulnerable to sudden cardiac death, with the majority of conditions being those that may have been detected during life, hypertrophic cardiomyopathy being the most common cardiomyopathy, followed by arrhythmogenic right ventricular cardiomyopathy. And thankfully, these conditions do have abbreviations for our sake as well. And dilated cardiomyopathy, where there's an abnormally enlarged heart, accounted for the remainder. I've mentioned that one of the main causes of sudden cardiac death are these heart muscle disorders, HCM or ARVC. And these are usually autosomal dominant conditions in which the ECG is abnormal in the majority of cases. In fact, in up to 90% of HCM cases and up to 60% of ARVC cases. But this leads me to the role of imaging, and in particular echocardiogram and cardiac MRI, and they play the most crucial role in helping define a clinical form of the disease. There are also other abnormalities such as abnormal coronary arteries, and that's not from an atherosclerosis perspective, but it's more a congenital abnormality pertaining to where the coronary arteries actually arise from. And there are other connective tissue disorders affecting the aorta, where we can see there's an abnormally dilated aorta here, and even premature coronary artery disease with conditions associated with hypercholesterolemia or familial hypercholesterolemia. Electrical disorders, however, have now been shown to cause more of an increasing role, which has been previously underappreciated. And we are increasingly seeing sudden arrhythmic death syndrome cases in our clinics, and we are therefore evaluating family members because unfortunately the deceased has demonstrated a structurally normal heart at post-mortem autopsy. And therefore, in order to find out, okay, there's no hypertrophic cardiomyopathy there or any other sort of heart muscle disorder, so this may well have been an electrical problem, in which case we then have to evaluate their family members, because there's a 50-50 chance that one of them could be affected. And you can imagine the guilt, the stress, the anxiety that such relatives have to undergo when they attend our clinics. And such conditions include long QT syndrome, Brugada syndrome, and Wolff-Parkinson-White. The top two of these are inherited in an autosomal dominant manner. I just want to talk about the different imaging modalities we use within sports cardiology, and that is to measure cardiac dimensions for the aforementioned reasons, to look at the different patterns of hypertrophy and wall thickness, look at the function of the heart, which is obviously crucial, particularly in exercising individuals, to see if certain areas of the heart are working or they're not, and to delineate the myocardial architecture and coronary anatomy, and risk stratify individuals, as well as assess response to any therapy that's indicated. And although such roles are evolving at a rapid pace, with constantly emerging technologies, we must bear in mind that along with bedside evaluation and interpreting the ECG, there is a patient at the middle of all of this with huge implications on their lifestyle. So any work that has been done at the bench side through to the bedside really is impactful in terms of lifestyle implications and familial implications as well, given the genetic predisposition of these conditions. I just want to give a couple of examples. So this is a 26-year-old white footballer who developed palpitations towards the end of a competitive football game. And without getting too much into the electrical tracing of the heart, the ECG, we can appreciate, for those who may be familiar, that this is abnormal T-wave inversion seen in V5 and V6, which is the sort of pattern that we look for. This is his echocardiogram, which shows the heart side on. And actually, it didn't demonstrate any particularly abnormal features, although the left ventricular wall thickness was at 12 or 1.2 centimeters, 12 millimeters, so at the upper limit of normal. Other views of the heart using echocardiogram didn't demonstrate any specific abnormality. There was a small pericardial effusion there, but the right side of the heart was also actually working fine, and more intricate tools that we do use, both from a clinical and research perspective, were also normal. Functional tests were normal as well. He had a very good maximal oxygen capacity and no arrhythmias on ECG monitoring when we fit them with devices to make sure that they don't have any funny rhythms in their own environment. But then this highlights the important role of the cardiac MRI, which showed a mildly thickened anterior wall that wasn't quite appreciated on echocardiogram. And when we looked at the cross-sectional views through the heart using the MRI, our attention was drawn to a focal segment there. And although function was preserved overall, one can appreciate here that this area of hypertrophy measured 16 millimeters and therefore was deemed to be pathological. But of course, labeling a young athletic individual with a cardiac condition does have implications on their own career progression, potentially financial implications, and on the family. And of course, there's a threefold increased risk reported of sudden cardiac death with continued participation of sport. So there are a number of ethical dilemmas that are also posed, and genetics as well. But I'd just like to mention a couple of newer techniques, such as T1 mapping, that has been shown to reveal an increase in myocyte mass. And we've heard a bit about the different roles that these modalities can play from Chris's talk as well. And there's a positive correlation between wall thickness and ECV, suggesting hypertrophy is mediated by a cellular disarray mechanism and extracellular matrix expansion. And I'd also like to just bring your attention towards left ventricular cavity size. So before I was talking about left ventricular hypertrophy, which is thickening of this part of the heart muscle, but cavity size is looking at the chamber size itself. And one can appreciate the difference between an endurance athlete and a sedentary individual. In fact, this histogram shows that highly trained male and female athletes demonstrate a cavity size that is way above what one would consider normal in clinical practice. So here we really are in the realms of what is going on. Abigail reported that amongst nearly 300 Tour de France cyclists, 50%, over 50% had a cavity size greater than 60 millimeters. We'd consider a cutoff of around 53 millimeters amongst females and 58 millimeters amongst males as abnormal. And a good, 12% had a low ejection fraction, which is the left ventricular ejection fraction, the ability of the heart to pump blood out. But at rest, we know that that may be lower amongst these individuals. And this is an example of a cyclist who actually won the Tour de France from the UK. And he has a greatly increased cavity size, and it raises the possibility of a dilated cardiomyopathy. Thankfully, his tests were all okay, but this is a common conundrum that we face in our clinics. We have to differentiate physiological LV enlargement from dilated cardiomyopathy. And a whole host of tools are available, but I'd like to focus on some of the more novel research tools, such as exercise echo and exercise cardiac MRI. And a colleague of mine, Lynn Miller, compared 29 athletes with dilated hearts with 27 patients with a dilated heart muscle disorder. So the 29 athletes had shown adaptive changes and had been extensively investigated to ensure that they don't have a heart muscle disorder. And they were compared to patients who actually did have a heart muscle disorder, and they looked at a variety of parameters, including changes in ejection fraction, the peak ejection fraction, stroke volume changes, and peak S prime, which is a global longitudinal functional parameter for those familiar with echo. But what we did show, it has since been published, is that the majority of athletes showed an increase in their ejection fraction 11% with exercise, compared to only 14.8% of dilated cardiomyopathy patients. So exercise echo is important. They also, she also reported the sensitivity of using 11% as a cutoff to predict dilated cardiomyopathy at 85%. So that's something that we do use, and this has since been published in Heart last year. Of course, the cardiac MRI is the gold standard to image such individuals, but we're sometimes limited by availability and the ease of access compared to echocardiogram. But again, this slide simply highlights slicing through the heart cross-sectionally, that we're highlighting areas of fibrosis here, and highlighted here and around the midwall and epicardial surface, which is pathognomic of a dilated cardiomyopathy. Exercise cardiac MRI is now also being used as a research tool, and a study recently published by Klassen showed that this modality also concurred with Lynn Miller's study, with, albeit only in 10 endurance athletes, but they showed an augmentation of ejection fraction by 14%. In the current climate of COVID, I think it's important to mention the role of MRI in COVID-19 myocarditis. And one can appreciate that this part of the heart is not working as well. And if we cross-sectionally go through, if I just draw your attention to here, this part of the infralateral wall isn't squeezing down as nicely as all the other parts. And gadolinium enhancement, which shows areas of scar, highlights that quite nicely in that territory as well, that there's scar tissue in an athlete who has been affected by COVID myocarditis and just was not able to return to anywhere near their functional capacity. Again, this is chartering into unknown territories, but databases are being formed now whereby young athletic individuals are undergoing a plethora of screening modalities prior to returning to play. I'd like to just mention the right ventricular cavity dimensions. The right side of the heart also shows dilatation amongst males and females, amongst black athletes and white athletes, that would be considered adaptations into the territory of arrhythmogenic right ventricular cardiomyopathy. And in fact, murine models have been shown to show that exercise plays a fundamental role in unmasking the phenotype. So there's an important link between exercise and outcomes of mutations amongst positive patients with ARVC, arrhythmogenic right ventricular cardiomyopathy, and family members, which is particularly relevant to athletic individuals because it raises the concern about competitive sports and participation in moderate to extreme physical activities. And the concept of exercise-induced ARVC is of great interest. Acute reversible RV damage may happen, and the pathogenic mechanism is due to myocardial stretch, leading to fibrofatty replacement, and that can clinically correlate, in the worst case scenario, with sudden cardiac death. And animal models have been shown amongst endurance exercise rats that there was an adverse remodeling amongst those that were made to exercise for 60 minutes daily for 16 weeks. And actually, after just 8 weeks of detraining, there was reversing of the fibrosis shown. This has been translated to humans, and 40 healthy endurance athletes have been studied immediately before, after, and 7 days after an ultra endurance race. And troponin levels, which is a measure of cardiac necrosis, as well as the right ventricular ejection fraction, was shown to be transiently stunned post-race. Therefore, it does raise the possibility that repeated injury, particularly in susceptible individuals, may unmask a phenotype. And this has now been demonstrated by many papers in the last few years, that endurance exercise is associated with a lower age of presentation and higher risk of sudden cardiac death, a more rapid progression to heart failure in patients with ARVC. And this has led to a concept nicely depicted by someone that highlights the balance between nature, highlighted by the blue bar, and nurture being the exercise and lifestyle amongst those who are positive ARVC patients or an ultra-endurance athlete. And finally, I'd like to just mention the lifelong endurance effects of exercise. So there's the normal aging process and genetic predisposition for cardiac disease later on in life. Risk factors that we sometimes can't do anything about, and the stress of exercise as well. This was a nice study by my colleague, Ahmed Merghani, and he took 150 veteran athletes and he compared them to 95 controls. And they were all early 50s. The athletes had performed at least 12 ultra-endurance events during their lifetime. But what they interestingly demonstrated was that there was more coronary plaque present amongst male athletic individuals compared to the controls. And in fact, nearly 8% had some degree of stenosis, i.e. blockage of their coronary arteries. So before I was talking about heart muscle disease, but the older one goes, 35 years old, 50 years old, ultra-endurance athletes do have a tendency to build up more coronary plaque. But the good news is that the plaque morphology was a lot more stable and composed of calcific hard plaque, as opposed to the mixed morphology or soft plaque that was present in controls and is more prone to rupture. And this is an example of an imaging modality, CT coronary artery, that shows a calcified vessel running throughout the myocardium of a veteran athlete. But the mechanism is not due to be, is not thought to be because of the inflammatory hyperlipidemia type cases in coronary artery disease. It's more the shear stresses that are involved with repeated bouts of exercise. Having said that, I want to finish on the beneficial effects of exercise that should not be understated. Of course, disease can manifest in predisposed individuals, but there's a multifaceted benefit. There are multifaceted benefits of exercise, both mentally, hormonally, associations with lower incidence of cancers, musculoskeletally, and of course on multiple cardiovascular risk factors. So my final slide is, we do need to ensure that that we move with rapidly, we move at a rapid pace of emerging technologies, not just our understanding of the ECG, which has been the longest standing modality to date, but still has.
So I'm just listening to the end of a talk as well at the same time.
Okay, thank you. Yes, this is the end of the talk, Mr. White. You're absolutely right. But I've talked about the role of echo. I've talked about MRI. I've talked about coronary artery angiograms and CT, and we do need to do more to find out why certain groups are more predisposed to sudden cardiac death. We have to accept that we're chartering into unknown territories with incidental findings. Longer term outcome data is required, and I wish to pursue that here in Manchester in collaboration with the FA data and emerging populations of Black, mixed race, Asian, female athletes as well. But echo is the most readily available tool. We depend on cardiac MRI for the diagnosis of certain conditions and CT for the diagnosis of other conditions, but we are limited by resources, the implications of our findings. We need to validate our methods, and of course, research is absolutely crucial to this. Many thanks for your attention.
Anil, thank you very much. That was a super talk, and I think you really brought home the extreme difficulty and challenge that you face in making decisions in some of these patients where, it's a question of degrees, and, if you decide that they need to stop, then this can be, an end to their career. That's a very, very challenging area of practice. Well, we have some questions in the chat, and we'll get through as many of those as we can. And I think, Anil, the first question, perhaps you'd like to take this. Is the inherently sedentary nature of office desk computer-based work going to lead to increasing rates of cardiovascular disease in the future?
Well, I think it's interesting that, I mean, one would assume yes, but then my experience has been that lots of people are actually getting out and exercising more, and that was, as I mentioned, one of the only things that we are allowed to do, were allowed to do during the national global pandemic and our lockdown. So I think lots of people did start taking up exercise. That then became a problem more around those affected with COVID. And we are beginning to see those sorts of patients filtering through now. And that's why I gave an example of a COVID-related myocarditis. Primarily, of course, it affects the lungs, but there is a cardiorespiratory component to that. So I think time will tell. I think being office-based or desk-based will probably give more of a rise to musculoskeletal issues more than cardiovascular issues in the meantime. But when the weather's as good as it is now, all we have to do is take a walk outside for 20 minutes daily, and that's the minimum recommended. And you know, I do implore everyone to do that.
That's great, thank you. So, Chris, there's a question here on advanced imaging using, or treatment using nanoparticles. You mentioned imaging briefly, but anything to say on treatment, perhaps?
Yeah, it's a good question. I mean, so the USPIO technique, which I described, that is a nanoparticle technique, and it would be great if we could both. The small particles of iron, we can detect that using cardiac MRI because they perturb or they change the magnetic field, so we can to some extent track where the macrophages go. If we could also deliver therapy using those same nanoparticles, we could track macrophages and track treatment as well, which would be amazing. But we're not involved with anything like that at present. Yeah.
Okay, then there are a couple of questions about peripheral arterial disease, which I'll put together. Perhaps I'll answer the question that, you know, peripheral arterial disease is a very important part of what's going on in the Academic Health Science Centre. There's some great basic science taking place, I think, at all the higher education institutions that is relevant to peripheral arterial disease. And there are some great clinical programs, for example, the Manchester Amputation Reduction Strategy and the work on diabetic foot disease, which is going on across the conurbation. So I hope that's a reasonable answer to that question. And then there's quite a big question, perhaps both speakers would like to comment on. What developments in the management of cardiovascular disease do you see entering practice in Greater Manchester in the next 5 years? So maybe you're allowed perhaps the two most promising things that you think are going to happen in the next 5 years. Anil.
Well, I'm biased because I'm the one about prevention rather than cure. So I do think, you know, exercise promotion is absolutely key to that. I think we are beginning to see the benefits of the smoking bans filtering through. I think culture has changed amongst younger people as well. Certainly the ones that we come across in our clinics and through screening, they are generally quite healthy individuals. So I think exercise promotion is key. I think addressing familial conditions such as hyperlipidemia, which is underdetected, is absolutely crucial as well. So I think, you know, addressing modifiable risk factors, hypertension, hypercholesterolemia in particular, is certainly worthwhile, because these are silent killers that can be modified, and differences can be seen in the next, you know, over the next 5 to 10 years.
That's great, Chris.
So I would say deeper cardiovascular phenotyping linked with personalized medicine. So along the lines of the kind of imaging techniques that I've demonstrated, we can assess the heart in much more detail and provide quantitative kind of assessment of things like fibrosis and more detailed function. Now, as we incorporate those into prognostic models involving other kind of clinical aspects of care, I think that over the next few years, we'll see better prognostication, better guidance of therapy, and I guess along the lines of what Anil said in terms of taking it back in terms of prevention. So identifying those patients who are going to develop heart failure in the next 5-10 years, identifying that early on with this better phenotyping, also pulling in genotyping to then try and address those risk factors earlier to hopefully prevent them developing heart failure in the first place.
So I think those are both terrific and very complementary answers. So Anil has focused on the population, doing what we know works in the population, and Chris has focused on the personalized medicine. I absolutely agree. I think if we can get those two things worked out, we can make a lot of progress. Okay, so there's a question about do you think it's possible to pick up potential early signs in athletes from a wearable single channel ECG? So what's the role of wearables, Anil?
I think that's an excellent question, and it's an area, and I think someone else has also asked about the interaction between wearable technology and phenotype of disease. So perhaps I can answer both of these questions. And more people are engaging. I mean, athletes, endurance athletes, and the veteran ones are arguably obsessed with what their heart rate does and how hard they can push themselves. And from a disease perspective, it is very helpful. Being able to pick up palpitations on a 24-hour tape is quite difficult, as you know from your own clinical experience, Bernard. But rather than going the whole hog and putting in a loop recorder, which is a small memory stick-sized device that we have to sometimes implant under the skin, and that stays in for 3 or 4 years. An Apple Watch can, for instance, detect something that you can record an ECG as soon as someone is symptomatic, but you have to be symptomatic with it. And it's a double-edged sword. If you can get good data, and that has been shown in huge studies published in The Lancet in America using the Apple Watch data and AF in particular, then that's great. But conversely, other wearables that can record all the time, but they may also detect incidental findings like 3 or 4 beats of a life-threatening rhythm that would actually otherwise be normal. And if you put a wearable device on the whole audience, a significant proportion would come back with, okay, a few skipped beats here, some broad complex tachycardia, for instance, and then you're opening up cans of worms amongst individuals where you wouldn't have otherwise done so. So I think, yes, there's definitely a role to play, particularly amongst symptomatic individuals, looking at their heart rate during their performance and trying to get an ECG trace when they are symptomatic. But the results do need to be interpreted in the context of that individual.
Yeah, and relatedly, Chris, there was a question about the interaction between wearables and cardiac MR imaging. Do you think there's an opportunity there?
Yeah, absolutely. So I think that so myocardial fibrosis, for example, that we measure with this ECB technique associates with things like heart failure, death, potentially sudden cardiac death. There's a paper we've got a paper under review at the moment led by a colleague that this ECV associates with appropriate ICD discharge, so giving people shocks. So it would be really interesting and that's quite a small study, but it would be really interesting on a much larger scale if we could have registries of patients or cohorts of patients who are undergoing cardiac MRI, for example, to acquire these detailed phenotype measurements, to correlate them with heart rhythm, atrial and ventricular arrhythmias that can be detected using wearables. So yeah, I think it could help us to understand the pathological implications of some of the detailed changes in phenotype that we can detect with cardiac MRI.
Thank you. And there's a question about COVID-19. You both spoke about that a bit. The specific question was what complications might be preventable. I don't know whether you might want to just expand that a little bit to talk about how large you feel a problem it is the cardiovascular complications of COVID. Anil, do you want to go first?
Yeah, happy to. Well, we know from observational studies that 15% of hospitalized individuals have some form of myocardial involvement, but that is the extreme of hospitalized individuals. And now data are emerging, recently published in JAMA Cardiology, amongst the general population that had milder symptoms, but still underwent return to play protocols that we have published in the European Society, or through the European Society of Cardiology. And they include a variety of tests, ECG, echo, MRI. What we have found is that using an MRI routinely detects less than 1% of myocardial involvement. So we're talking about a small proportion of individuals. But when a more tailored approach is used, the American experience was that the detection rate goes up, the sensitivity goes up for myocarditis fourfold to just under 3%. So I think appropriate use of the appropriate modality is obviously crucial to finding what you need to find. And to answer the second part of the question, which was any advice to be given, usually what we say to athletes is you have complete rest for 7 to 10 days post resolution of your symptoms. And that follows standard advice that we'd give for any post-viral illness to ensure that there's no subsequent pericardial or myocardial involvement.
So just to add very briefly, I agree with all of that. I think the jury is still out a little. There's been quite a lot of data published on sort of in the non-athletic population in terms of particularly cardiac MRI detected myocardial involvement by COVID. And I think that they have maybe been quite selected populations, and they, I think that the big studies, the UKRI funded studies going on, particularly in the UK at present, which involves sort of COVID hard is around 370 patients, CMOR is around 500 patients. I think that they will tell us definitively, or more definitively, kind of amounts of myocardial involvement. These are often old. The people who are admitted are often older, have lots of comorbidities. How much of what we are seeing on cardiac MRI would we have seen anyway if we just scanned lots of people with these comorbidities? So I think that we've got a bit of a guide so far from what's published, but I still think we don't really know. Also, very briefly, in terms of what we're actually seeing in some people, whether it's an inflammatory pathology that we see, or whether it's some kind of like micro angiographic thrombotic thing which is causing small infarcts and subsequent inflammation, I think the jury on that is still out. So we see some quite odd patterns in the myocardium in those. So we do think that there is COVID involvement in the myocardium, but yeah, lots that we don't know.
Okay, that's great. I think we're going to probably have to stop there. We've gone 7 minutes over. Thanks very much for everyone who submitted a question. I'm sorry that we didn't manage to get to everybody's. And let me just thank both speakers for a pair of really super talks and some very illuminating and lively discussion. And thanks to all of you for your attendance. The next MAHSC seminar is, I believe, on the 28th of April. So I hope many will be able to join us at that one. Thanks very much and goodbye.